Welcome to the Evidence-Based Pilates Podcast, and we have an incredible episode today because I have the one and the only Terri Elder on the podcast today. Welcome, Terri.
Hi, thanks for having me.
Yeah, it's incredible to have you. And for the listeners who are unfamiliar with you and your profession, could you give us an introduction?
Sure, absolutely. And I just want to say, I'm just so excited to be talking to you because you and I have been knowing each other on Instagram for a while and following each other. And but yeah, to introduce myself, so I am a pelvic health physical therapist, and I'm also a coach, a pregnancy and postpartum coach for Street Parking, which is an at-home workout program. And then I teach. I have a few different various teaching positions as well with Western Carolina University, Georgia State University, and their physical therapy programs. And I just, at the core, am like a movement optimist, and I have a long career in fitness. I started as a massage therapist 20 years ago. And then shortly after that, actually got my Pilates mat certification. I don't know if you know that I started as a Pilates teacher before PT school. And I still also do Pilates every week, even though I also do a lot of strength work, Olympic lifting, dabble in all of the functional fitness stuff as well. So that's a little bit about my background. Yeah.
Sounds like you have tons of free time. Oh my gosh.
Oh,
Uh, we all specialize in that, don't we? But that's awesome. I didn't know that you were first a Pilates instructor and then a physical therapist. So that's very familiar to myself as well. So cheers to that, and cheers to any Pilates instructors thinking of becoming a physical therapist. You can do it.
yeah.
With that said, I reached out to you the other day because part of my work is being a mentor to individuals in the Pilates industry within the VIP membership, as well as just friends. I was getting a lot of questions around intra-abdominal pressure management, as well as pelvic organ prolapse.
Mhm.
And it's not a specialty of mine, right? It's like I'm vaguely familiar, and I felt like I'm not the best person to ask for this. So I thought, why not reach out to an expert, have a conversation, and help uplift the Pilates industry or just any fitness educator in the process. So that's essentially where this conversation is. I think it's going, and we'll see where it ends up.
Sounds
But
good.
with that, is that fair?
Yeah, absolutely.
All right, let's
I
dive
love
in.
reaching out to other experts. That's the best way. And even within, pelvic health, there's other people who are more like neuro pelvic health or, peds pelvic health or like little subspecialties that I frequently am like phoning a friend and reaching out.
Yeah, there you go. Always have the phone a friend. You know, trick in your back pocket. With that said, for those that are unfamiliar, could you discuss like what the pelvic floor is, as well as its function?
Yeah, absolutely. So the pelvic floor is a series or a set of muscles, ligaments, nerves, connective tissue that sits at the base of the pelvis. And so it's not just muscles. A lot of people think pelvic floor is being like just muscular, but it's all kinds of things. And it helps, the main functions are maintaining continence, so keeping pee and poop in, but then also letting it out when it's time. And there are people who have problems with both, keeping things in or getting things out. And there's also, of course, sexual function. There are support, and that is a big part of what we'll be talking today about as well. And then there's also some lymphatic functions as well. Pelvic floor and associated structures also help to return lymphatic fluids with circulation, things like that. But really, the pelvic floor helps to coordinate with the whole system to manage pressure. So that's a big component of what it does.
Well said. And in terms of like exercise, how does it function during, like, whether it be Pilates exercises or something as simple as like a squat, things like that?
Mm. So I do have actually a couple of different models to show. So for those of the people who are listening, hopefully there will be visual recorded version that you can go to, or you can just kind of look up some basic pelvic floor images on Google if you would like later. But essentially, so this is a little pelvic model that I have. And I just wanted to start with a little bit of kind of more visuals and show that. So this is inside the pelvis. The sacrum is here at the back. The pubic bone is here at the front. And so if you can imagine that this is the pelvis, this is another view of a bony model, kind of sitting the same way. Then from the bottom up looking, you can see there's another set of muscles. So there are 3 different layers of muscles, and there's many different kind of muscles within each layer. So there are different muscles that have different parts that they're more important for certain parts of the function. For instance, these, and this is a model that has a vulva, but I do want to also say that in individuals that have anatomy with a penis, the pelvic floor is essentially the same. There's just one extra hole for the vaginal opening, and it's shaped differently. Okay, so all of the muscles are the same. Yes, men have a pelvic floor too. Everyone with a pelvis has a pelvic floor. So there are muscles kind of at the front around the urethral opening that are more important for maintaining continence, helping support the urinary sphincters, muscles at the back that are more important for helping with fecal continence or keeping the poop in. And then the deeper muscles in the pelvis are more important for kind of organ support. They all function together, and you can't isolate necessarily one over another, although you can kind of bias the front and the back. So in exercise, the muscles are working kind of dynamically to, again, help maintain continence, say during a squat. Also to help generate pressure, and we'll get to intra-abdominal pressure, I know, but what happens in the pelvic floor during a squat really depends on what that individual's nervous system chooses. So there's a lot of variability in what happens during the pelvic floor during a squat. I don't want to go too far down that road quite yet. Do you have any questions about that, or is there any clarification you want?
Is there a wrong way to use your pelvic floor during a squat?
Good question. Okay, so is there a wrong way? Aside from, I don't want to get dark, but aside from assault, there's really no wrong way to use your pelvic floor. So really, there are things that people want to say are safe and unsafe. And I want to say, like, right at the front, that I am in the gray, and I love being in the gray. And even though I'm wearing a black and white top, and I didn't mean to do that, I really don't love this safe and unsafe, good and bad, because there are different things for different people. But I do come from, and I start from a place of movement is safe and movement is good. Okay. And I kind of think that we have to start there, because a lot of people want to demonize, oh, everybody needs Kegels, nobody needs Kegels, this and that. And, we have to come from a place of that it's safe in general to move our bodies, and it's good to move our bodies. And there's so many benefits to that. Now, there are certain strategies that people might be using during movement or during like squats, say, that might be causing them symptoms. Does that mean that it's bad for them? That's a different question. Because something causes symptoms doesn't necessarily mean that it's bad. It just means that it's symptom provoking. So the only thing that I would say that might be a strategy that might be detrimental kind of long term is a lot of really, really heavy bearing down through the pelvic floor with a lot of movement. That would be the one kind of stretch that I would have to, to do. But I don't want to completely demonize that function, because bearing down, lengthening your pelvic floor is important for being able to go to the bathroom, for pushing out a baby, for those things as well.
For listeners that are unfamiliar with the term bearing down, could you clarify what you mean by bearing down?
Yeah. So that's a great question, because there is a lot of confusion even among pelvic PTs and the research that you read. And there is really such a difference between holding your breath and bearing down. So holding your breath is also known as a Valsalva. And that is quite different from bearing down, which bearing down can be done with or without a breath hold, but it's essentially pressure being directed down through the pelvic floor with no pelvic floor contractions, so that really it's just pushing down and out. And so you can take a breath, push down, and have a control of your pelvic floor. And in which case you're not really bearing down, you're kind of controlling that pressure, if that makes sense.
Totally makes
So I
sense.
do want to say one more thing about the difference between a breath hold Valsalva and bearing down, because there is a big distinction. And I think this is a really great way for people to kind of think about a Valsalva or a breath hold. It is more like trying to clear your ears. Like if you're on a plane and you take a breath and you're directing pressure up cranially through and out your ears, your diaphragm actually stays where it is, where it's relaxed. Whereas with bearing down, your diaphragm is descending, your abdominal contents are descending, and there's also a descent of the pelvic floor.
Thank you for clarifying. What bearing down is and how it differentiates from Valsalva.
Sure.
As
And I
as
will say,
I
even sorry to break in, so much research also uses the terms interchangeably as well. So if you see Valsalva, you have to like read the context and say, are they talking about bearing down? Because a lot of times they will, because they want to sound clinical and they want to sound, so they use Valsalva, but really they mean bearing down a lot.
There you go. Absolutely. I learned that yesterday when I was watching your your seminar on
Ah,
changing pop culture. So that was such a good seminar. I highly recommend it. With that, what are you mentioned like if they're like during a squat, like if something became symptomatic, can you describe what like if someone was having like pelvic floor dysfunction or they were having symptoms related to the pelvic floor, what
mhm.
are those signs and symptoms?
Sure. So a symptom, if we're talking about pelvic floor, it can be feeling of pressure, feeling of leaking, so leaking urine or leaking feces. Pain is another symptom, and that can be also like, so that can be pain in the pelvis region, kind of anywhere. We talk about pelvic pain, like lower abdominal pain, pubic symphysis pain, SI joint pain, low back pain, hip pain. Like that's kind of all like that whole area. Pain can be kind of in that area as well. So sometimes movement, a particular movement or a particular strategy might provoke a symptom. Again, that doesn't mean that it is causing damage or bad, right? Especially in the case of pain. And we also have to think about incontinence that way as well. Well, if someone does leak when they're doing exercise, does that mean that they're doing damage to their body? And that is a huge question actually in the pelvic health field. Um, and you do have to really take into account the fact that we don't really know, if there is like permanent damage being done, say to the urethral sphincter. You may be kind of like worsening your incontinence over time, but you have to weigh that against the very well known and very well established benefits of exercise. So like, are you gonna, and so many people do restrict their exercise and restrict their movements because of pelvic health symptoms, because they think, oh, I'm having these symptoms, I'm gonna do more damage if I do that. And so they restrict, and they, do less and less and less. And their bodies become less resilient and they're less able to tolerate heavy loads, heavy things, and things do tend to get kind of worse over time. So I think the symptoms can sometimes also direct us to an exercise or a movement that's actually a really good thing to be doing, because you can use that symptom to maybe find a different way to do something, or a threshold to kind of push and work into something that is challenging for that individual.
Wonderfully said. And when it talks to, so that's in regards to like signs and symptoms and how we can help manage that through exercise appropriately. And then specific to like pelvic organ prolapse, for the listeners that have maybe heard of pelvic organ prolapse, POP is the cool way to say it, dear listener. And for those that are unfamiliar with this, could you describe what a POP is?
Sure. So pelvic organ prolapse is also vaginal prolapse. So it is considered to be kind of in a different category from, say, like rectal prolapse, but it is essentially the descent of your pelvic organs pressing kind of into the vagina and sometimes beyond the vaginal opening. So there was a recent update in the kind of clinical definition of prolapse. And so to meet like a clinical criteria, meaning like you go to your doctor, you get like a medical, like, diagnosis of a prolapse, the organ descent needs to be at least coming down to the vaginal opening or beyond the vaginal opening. And you have to have symptoms that are bothersome. So you have to have both those bothersome symptoms and that physiologic anatomic descent. So there are some individuals who, have those symptoms, or they've been told, you have some organs descending, and they think, "Oh, I've really got prolapse. I've got this really mild prolapse someone told me about at my kind of postpartum checkup," and they're told like, "You're never to do heavy lifting again." And this is what happened to me. This is, I know you if you watched my seminar, you heard my story. When I was newly postpartum, I went and was diagnosed with this stage 1 to 2 pelvic organ prolapse, which just meant that there was a certain amount of descent happening on bearing down. But now research has been done, so much research has been done that helped us recalibrate what normal is. And we found that like 50% of 20-year-olds who've never had a baby have the amount of organ descent that I had. So that is now considered normal amount of organ descent. And we've kind of like this last couple of years, it's like, oh shit, we've been pathologizing this thing and restricting people's exercise for something that doesn't necessarily mean it's going to progress. It doesn't, is not an indicator that, it is not a progressive disorder necessarily. So I went off on a bit of a tangent, but kind of coming back to what prolapse is, it is not just a issue in the muscles, but the connective tissue. So the fascia, the ligaments of the pelvis, we have lots of strong ligaments. And so if someone does have anatomic descent to or beyond the vaginal opening, then they've got some changes to their connective tissue. They may or may not have changes to their muscular support. And so that's an important thing to note. And I will also say just one more thing about the importance of the symptomatic bother is that someone can have huge symptomatic bother, but have really relatively mild prolapse. And people can also have pretty significant anatomic prolapse and have fairly mild symptoms. So they don't correlate. And unfortunately, they're not like a reliable indicator of what is going on.
That's so fascinating, and I start to think of how we see that in other aspects of the body, right? If someone takes like an MRI of a spine and then tries to relate it to low back pain, sometimes it's not really associated, or like grades of osteoarthritis and knee
Exactly.
function, things of that nature. So it seems like a very familiar story shown in another body part. And s-
Absolutely.
and so, how would you, if a Pilates instructor was working with a client and they said they had pelvic organ prolapse, is it safe to work with that
Mhm.
client?
Well, I don't love the safe and unsafe.
I know, that's
However,
why I asked it that way.
I'm gonna come from my, movement optimist kind of like we have to start at that, you know, in general, the benefits are going to outweigh the risks, okay, for exercise. And you can certainly help people move and help people feel strong in their body despite them having a pelvic organ prolapse. And in fact, I would say it's very beneficial that people need to stay strong and need to stay moving when they have pelvic organ prolapse. So that's what I'm going to say. Yes, safe. You got me.
There you go. And so then with that, we want to keep people moving because an individual with pelvic organ prolapse also has a cardiovascular system. They also have thoughts and feelings in a life that they want to do things. And
Right.
then as a Pilates instructor, we want to help people. I'm under that assumption that we want to do that, but we also may be unfamiliar and don't want to hurt people.
Mm.
Are there certain exercises within the Pilates repertoire that you would recommend not teaching to people with pelvic organ prolapse?
No, not at all. Because so if we talk a little bit more about the kind of the pressure system first,
Yeah.
and intra-abdominal pressure management, then I think that will help give a little bit more context to answer that question. Um, because basically, so can I start there?
Yeah, let's do that.
Okay, just remind me to come back to that question if I don't answer it. Which was essentially like how best to help people with prolapse, because I know that is a huge issue in Pilates world, because Pilates has been like stamped as like safe, low pressure activity for people with like joint issues and prolapse. And so like all these people are coming to Pilates and they're like, oh, how do we best help and serve these individuals? So, so starting first with like that kind of intra-abdominal pressure system and pressure management, which is a really ambiguous term that is kind of hard to really put your stamp on, but it's essentially the pressure system. A good way, and a way that I like to think about it, and this is kind of like old PT stuff. Mary Massery is like the soda can, right? So if you think about your abdominal wall as kind of the walls of a soda can, the top of the soda can being the diaphragm, and the bottom of the soda can being the pelvic floor. And those, the abdominal wall is really the transverse abdominis, and also multifidus is included in there, some of the deep spinal stabilizers as well. I kind of think of like the abdomen all together, because guess what? Your obliques and your rectus and many other muscles are contributing to your pressure system. Anyway,
Mm.
those muscles are all dynamically working to moderate the pressure in your abdomen. And a lot of people want to kind of demonize pressure and say that there's this kind of underlying current that pressure needs to be managed and needs to be minimized, right? But pressure is really, really important to stabilize your spine. And that is one of the things that it does, right? So it is protective, and it has a function. Um, there are other two kind of big components, not just anatomical components, but the gravity. Okay, so the position that you're in does make a difference, and a lot of Pilates happens, in the kind of laying down, gravity neutralized kind of position.
Mhm.
Um, and then also acceleration, so how fast someone might be breathing, or the speed with which those changes occur to the muscles, also kind of like plays into how the pressure is managed. So um, I already mentioned Valsalva versus bearing down, and so that concept is important to kind of help us think about pressure. And so if you imagine that the canister is getting smaller, so with an abdominal contraction, especially with like, Pilates kind of navel to spine, things are getting smaller in the center, right? That pressure is going somewhere. So we're breathing up and down at the top, and the pelvic floor is also moving. And that's good. We want it to move. So these things are all happening really dynamically, and our nervous system is constantly making these choices because we cannot be thinking about them all the time, right? So, if you want to get into like a lot of nitty gritty with studies that are done on intra abdominal pressure, they have done so many studies looking at what pressure is exerted specifically kind of onto the pelvic floor
Mhm.
for pelvic floor kind of concerns. But sometimes they're also measuring just like what is happening in the abdomen, with what seems like fairly uncomfortable kind of methods, like having a needle in your abdomen when you're like trying to do these movements, or having like a vaginal sensor in place. But anyway, um, the studies that they have done on intra-abdominal pressure And there are many, many varied, I'll try to kind of give it in a nutshell. There is a lot of variability between individuals in how they manage pressure, and also within the same person doing the same movement. They'll do it differently at different times. And the movements that are the highest pressure, we are already doing in our day to day lives: coughing, sneezing, and getting up from a chair. So the highest pressure movements that people are doing in Pilates are usually getting up and down off of the reformer or off and onto the mat. So I just put a little pause right there. What does that mean?
Yeah, I actually there's a paper in the pop culture
The
seminar that you
Coleman,
did with Anthony.
Coleman et
Why
al.
am I
from
forgetting the
2018.
yeah, Coleman et al. So it's in
Yeah.
the show notes for anyone. It's titled "Intra-Abdominal Pressure During Pilates Unlikely to Cause Pelvic Floor Harm." And
Yes.
do you want to speak to that study,
Sure,
Terry?
absolutely. So it is, it's such a cool study if you want to look at it. It's the Coleman et al. 2015. And they looked at the mean or the average and the maximum intra-abdominal pressure during all these different various Pilates mat reformer exercises compared to that kind of sit to stand movement, which was found to be like a fairly high pressure kind of activity of daily living. And basically, all of the movements were found to be lower than just standing up from a chair. And that included like the highest one was the Pilates mat roll up, and the kind of the lowest one was the reformer with like segmental bridging. And you can imagine that would be the lowest one, right? Because your pelvis is kind of being lifted up. And so that gravity has kind of like a negative pressure effect. Whereas with the Pilates mat roll up is like a higher pressure one. It's still, even though that was the highest pressure one that they looked at, is still lower than sit to stand. In some of the other studies that we cover in the seminar, um, sit to stand is still even lower than coughing, sneezing, or getting up from laying down, which happens in Pilates all the time. And they didn't look at, in that study, they did not look at like standing tower, some other stuff. This was kind of
Yeah.
looking mostly at the more supine sideline prone movements, but it's still really interesting and illustrates the fact that we're already doing these high pressure activities. And so, I hope this helps ease the minds of those who are listening that Pilates is, in fact, a fairly low pressure activity. And that doesn't mean that it won't necessarily give someone symptoms. And we can support people when they get symptoms during Pilates. And even though we can acknowledge that symptoms are not necessarily good indicators of what is happening to the tissues, we can still use those symptoms as a way to understand that maybe we change the way that someone is doing an exercise so that they can feel safe in their bodies and manage those symptoms. And there are lots of different ways to manage symptoms during movement.
So it sounds like you would draw back on like symptom modification.
Yes, definitely.
Yeah, I would do the same thing if someone has like knee pain,
Mm-hmm.
right? Do some kind of like there's a symptom, so we might modify it. Now,
Right.
in regard, or did you have
Yeah,
something to
I
add to
just
that?
want to say, just to take care with the messaging when you when you help someone find a different way to do something. Sometimes that's just a temporary, find this different way to do that, and then we want to get back to like, well, how is that now? Like, that doesn't mean that strategy is off the table, that movement is off the table. It's just that's causing symptoms right now. Let's find a different way, and then we'll come back and kind of test that.
Yeah, I'm so glad you brought that up because a lot of times people are told, particular movement rules, whether it be from like a pamphlet that they get from a healthcare practitioner, or advice they get from a physio, personal trainer, Pilates instructor,
Right.
and sometimes they're not given that timeline. I see it with people with scans too. They got a scan in 1993 and they think they still have the thing.
Right.
Um, and so it's important to refer to like this is temporary,
Yeah.
just like you mentioned.
Yeah.
And in like, would you, in regards to pressure management in Pilates specifically, is there any like thing that you would do to manage the pressure based on like what we saw in the Coleman paper, as well as your personal experience?
Not necessarily, not unless someone is something specifically is causing someone's a symptom. I wouldn't say that someone necessarily, say someone like walked into your studio, they told you they have prolapse, and we can get back to like what things you could consider if this happens. But I would not necessarily say like, oh, in that case, you need to only be doing XYZ or there's certain things that are off the table. Absolutely not. I would still take them through a process of, you know, movement exploration, finding out what was symptomatic to them, finding out what their baseline is, because there are plenty of people who are super strong who also have prolapse, and some people who are incredibly weak and debilitated, and they do not have any, organ descent considerations. So we can't really lump people, based on, oh, you have pop, therefore we need to be doing X, Y, and Z. So I would just encourage you to have the conversation with them if they're open to asking, telling you about it, and it's depending on who's listening and where they're practicing and what the scope is. Um, you know, ask them to just let you know when they are having symptoms, and we can talk about what those symptoms may be if you'd like.
Mm.
But I do want to make sure. I think I've lost track of what your question was. Did I answer it?
I like the road you went down. It
Okay.
was keep going. You're in the driver's seat today.
Okay. um, so the symptoms of prolapse are basically feeling of a bulge. That is the most kind of um, tangible symptom that has been related to what is happening in the tissues, is the feeling of a bulge, a feeling of a stuck tampon. Some people talk about heaviness or a pressure type feeling. But again, I will say that symptoms don't necessarily match up with what's happening. And there's a lot of central sensitivity that happens in the pelvis, especially with a lot of the messaging around pelvic organ prolapse. But those symptoms, still, there's different things that we can do to modulate those symptoms. Um, and, again, it depends on the setting. Are you working one-on-one with this individual? Is it a duet? Is it a group class? You're going to be a lot more limited in a group class. And so in the case of a group class, I would just encourage them to, um, that their nervous system can make good choices. And that if they want more tailored information, to encourage them to work with someone one-on-one, to be quite frank. I don't think that someone who is managing a group should be responsible for helping someone modify symptoms or navigate symptoms that way in a group setting. Is that fair?
Oh, totally fair. And just for clarity, that would be someone with POP that is symptomatic and Pilates is provoking their symptoms.
Hmm.
And then I would assume, and I think it's just helpful for the listener, for someone who maybe they're having symptoms outside of the Pilates studio, but Pilates hasn't really provoked their symptoms. How do you feel about them being in a group class and just being a part of that social environment?
Yeah, I mean, I think it's absolutely great. People need community, and group exercise is so great for um, mental health as well as the physical health. And that certainly is, Pilates is so great for general strengthening, for helping to create a more resilient system, for providing novel movement, so many different benefits. So absolutely, I don't think that just because someone has POP that they need to necessarily always only work one-on-one. I just want to put the Pilates instructor's mind at ease that they're not responsible for all of that in a group setting.
You have from I hope that felt good, group instructors. Like take an exhale. And
Yeah.
speaking of exhales, in regards to an individual that has POP, symptomatic or asymptomatic, what are your thoughts on the necessity of teaching specific breathing patterns?
Mm, that's a really good question. Um, so I will be honest. in the Pilates that I do, I breathe however I want. I do not follow the instructor's cues to breathe because I just want to breathe how I'm feeling in the movement. And, you know, I think that variability is also great. So there is no one right way to breathe. You know, so many times people are taught like you have to contract your pelvic floor on an exhale. But we need to also contract our pelvic floor on an inhale, because what happens with a sneeze? We're inhaling, 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 and then we sneeze with a huge, one of the biggest pressures that we can have. And your pelvic floor should be on at that time, because if it's not, things are going to happen. So we need to be able to have our pelvic floor be functional at different parts of the breathing cycle. And there's no one right way to breathe. I think that there are many, many benefits to actually breathing differently than you're used to. So, shaking things up with your class, if you're always, inhaling on the extension, try doing it the other way, because it is good for your body to have that variability. And I could go off on more tangents, but I'm going to stop there and ask me if you want me to wrap that up in any other kind of a bow.
You are the driver today, Terri. I'm just here as a student and enjoying the time.
Okay.
And wonderful answer. If I were to reflect that back in my understanding, it sounds like you wouldn't be too hard on having a specific breathing pattern or technique for an individual with POP in a Pilates class.
Yeah, with POP or with any other kind of pelvic floor symptom.
There you
Yeah,
go.
even holding your breath. As I mentioned, a breath hold is not necessarily bearing down. Some people do breath hold and bear down, but holding your breath is really, really important when you're managing heavier loads. And so for the Pilates instructors who might be listening who also do heavy weightlifting, and I will say that for some, especially like older individuals or people who have been hospitalized, sometimes getting up out of a chair is a 1 rep max squat. So that is heavy lifting for some people. Telling people always that they should be breathing through that movement is not correct, to be quite black and white about it. So, because a breath hold strategy is a way to stabilize the spine, and people can have sometimes better pelvic floor control with a breath hold. So if you're working with an individual, say one-on-one, and you have all the time in the world, and you are working with them through some symptom modification, like let's see what feels better, let's see what doesn't feel better. Try exhaling on the symptomatic movement. Try inhaling on the symptomatic movement. Try a breath hold, and you can do a submaximal breath hold. So your breath hold doesn't have to be like a full, huge breath. And in fact, a lot of people have a better pelvic floor contraction with a submaximal, meaning like your lungs are not all the way full breath hold. And ask them, does that feel better, worse, or the same? Try it this way. Does that feel better, worse, or the same? And see what I always like to kind of see what people's nervous system chooses first before I cue them, both for breath and for pelvic floor.
So if I love that answer, by the way, and I love how you are really speaking through the concept of living in the gray, despite wearing a black and white top. And it sounds like if it again goes back to like what's the human experiencing, like are they symptomatic, and then if they're symptomatic, that could be one strategy that you utilize, and that strategy seems non-specific. It's like what's going to work for that person, and that would be in a one-on-one setting, because that's basically impossible in a group setting.
Yeah, I believe. Yeah.
Is that fair?
Yeah, it is fair. And, just to kind of put that into context, what is, I don't know, what is in working with someone in a Pilates, what, studio, something that you have had someone tell you is kind of symptomatic before? Have you ever for prolapse?
For prolapse, prolapse specifically, I've had people complained of like incontinence, but they weren't
Okay.
specific about their diagnosis. But and it was one of those that I chose not to go there and invade
Right.
their privacy. But I would say incontinence, like with
Okay.
jump board or
Okay. Yeah.
vertical movements. Yeah.
Right. Okay. So let's take the jump board. And that could be one that could cause, pain, incontinence, prolapse symptoms, what have you. It could be any, regardless of what the symptom is. I know that the first thing to kind of jump to as well, let's just not do that. Because that's like the easy thing. It's like, oh, let's just move to the next thing. But, especially if you're working one on one with someone, like, how can we do that differently? So that is the big thing. Just do something different. And there are lots of different ways to do the different things. So try a different breath strategy. Is that better, the same, or worse? You can, of course, try different, tension on the spring, different amounts of jumping and pressure, different pelvic positions, different rib positions. So many different things to try: position, breath, resistance. And then symptoms might also be different if someone is, at the beginning of class versus the end of class, if they're coming in the beginning of the day or the end of the day. So the fatigue and their overall capacity can really be different, depending on also like what sort of bladder irritants they've had that day. Did they just have like a huge cup of coffee? So of course might be more than you get into like in a Pilates class, but um, knowing that symptoms are going to be variable, they're not always necessarily going to be the same, is an important concept. And for more on this, if you're really like, if you're loving this talk on like symptom modification and like what are all the things that we can do to like change the symptom, my colleague Teresa Wasser has a fantastic course for physios and fit pros. It's called TIPS FC, TIIPPSS and it's an acronym for like all the different things that you can change to kind of modify symptoms. So check her out, Teresa Wasser, Waser. She's great.
That is in the show notes for anyone who
Yeah,
did not write down that 17-letter acronym.
great.
Great stuff. Now, one thing I had done, and thank you to anyone who listens and engages on social media. One thing that I did was I asked the community to like what questions would we have for you, and I have a round of questions that if you don't mind, we can go through.
Awesome. Let's do it.
That sound cool?
Yeah.
The first question that I grabbed, because there are a bunch, was if Pilates instructors, just to general public, not pop, just general public,
Mhm.
if Pilates instructors choose not to cue pelvic floor, is that okay?
If they choose not to,
Yeah, like you're just teaching Pilates and you don't cue it. But let's say the studio manager is like, you need to cue this and you don't feel good about it. Is it okay to not cue it?
it is 100% okay not to cue the pelvic floor. Your pelvic floor is working regardless of whether or not you are thinking about it or cueing it. And in fact, even so, there's a really cool study that looked at maximum volitional contraction. So people would squeeze their pelvic floor as hard as they could, and they can test like exactly how much pressure people can exert. And then they looked at what pressures people were exerting throughout their day, and actually running an impact automatically contracting more than you can volitionally do on your own. So the pelvic floor is working, your nervous system is choosing, making choices to contract, relax, and kind of do its thing. And so I think 100% you don't have to cue the pelvic floor for the pelvic floor to be like getting a workout.
Well said. How about for prenatal populations? Would you cue pelvic floor for any support or preventative management?
No, not necessarily. I mean, I think that there are, for prenatal or individuals who are pregnant or trying to get pregnant, there are certainly benefits to doing pelvic floor exercises, um, and to getting strong in your pelvic floor. But there's also a whole lot of benefit for pregnant individuals to learn to relax their pelvic floor, especially because that is how generally most often the baby is going to come out. So um, it's, good to strengthen. It's also good to relax. And whether or not all of that can be addressed in a Pilates class or session is, I don't think that that's a fair expectation for an instructor to be able to target strengthening or target relaxation of the pelvic floor in a Pilates setting.
In a group setting or in a one-on-one setting?
Hmm. I
Or
think
both?
I think in a group setting, definitely not. Unless you had, say, like a prenatal like series that you were doing and you were all doing things together, that might be one area where people might be able to do some, pelvic floor focused kind of work. And so I would, in that case, I would say, it's not just about the strengthening, but also about the relaxation. And so but in the one-on-one, I that's a harder question to answer. I have a hard time separating myself from my education being, being a pelvic PT. I will say, you do not have to be a pelvic PT and you do not have to be even an internal PT and therapist to address the pelvic floor, to help people with symptom modification, to help people get stronger, to help people with their concerns. But it can be really helpful to have some additional education, more than one podcast can offer, for kind of what to do and what not to do for all of these various public health complaints for every individual.
Would that be like for people that are currently symptomatic? Is that what you're referring to? Or for people, yeah. Like, is that what you're referring to, just when people are symptomatic?
Um, if someone is symptomatic and they're coming in and working one on one, then I think that, yeah, definitely you can help people, even if you're not an internal, you know, physio. There are certainly some, fitness professionals and Pilates professionals who have additional training kind of in pelvic health who can, or in symptom modulation, symptom modification that can really, really be helpful, sometimes even more so than the internal therapist. And it can be really great to collaborate, and to be able to, with, of course, the client's permission, find out kind of um, what is going on with the pelvic floor, what the goals are, what are we working on, and how can I be a supportive kind of part of the team. And I just don't want people to think that if you're not an internal therapist, you can't help people with pelvic floor things. But I also think that if you are not an internal therapist, you can't be expected to like manage the whole thing yourself. Do you know what I mean? You can
Yeah,
help,
like,
but also like it's not all on you.
there you go. Be a team player, and it's really in the client's best interest. And what would be like? This is my own question now. Sorry, everyone. What would be an experience for a Pilates instructor that would warrant with the client's permission, a referral to an internal therapist?
I think anything that someone is having some symptoms that you don't feel comfortable or you don't feel like you are able to help them in the way that you want. And then you can also offer it as an option, not necessarily as like, I'm recommending that you go see XYZ, but like, hey, I have this colleague in the community who is a pelvic therapist and they're awesome. If you want to like learn more about your body and we can even talk and collaborate if you want, feel free to go check them out. Now, when I would make like maybe a stronger suggestion is if someone is having, significant pelvic pain that is really impacting what you were trying to do with them,
Yeah.
um, or significant symptoms that are just, you feel like you're over your head and your whole session is you're just trying to like, you can't help them move. They're so flared up. Um, you know, Time to phone a friend.
There you go. And don't be afraid to to just refer and collaborate with others in the community. And it's not a threat to your business. It shows your professionalism and it really puts the client forward.
Yeah,
Um,
absolutely.
and so, but with that, the next question from the population or the public was, how can Pilates help someone with pelvic organ prolapse? Like, can we be helpful?
I think absolutely. I think that um, Pilates, like I mentioned, like you are helping people, get stronger, get more resilient, pressure management, even if you don't necessarily like it still sounds like a very ambiguous term. It's because it is. Um, you are, helping people move their bodies, feel strong in their bodies. The group dynamic can be really powerful, but helping people like build resilience and feel good in their bodies, um, especially if it's their kind of preferred way to move, is great. Um, what I what I want to, also say is that, Pilates is often the thing that our people are told to do because their preferred method of exercise is being taken off of the table for them. And so, people might come in with like a chip on their shoulder or they don't like really want to be doing it. And like that's always fun for an instructor, right? So how can we also, help people ease back into the activities that they want to be doing? Because quite frankly, a lot of time these activities are being taken off the table. They really don't necessarily need to be, or it needs to be only kind of temporary. And then we can kind of help bridge them back into some of their more preferred movements. And that the movements that are often kind of like demonized, like heavy lifting, um, and things like that are not off the table for someone with pelvic organ prolapse as well. So, Pilates is great, and all of these other things can be great too. And really, the best type of exercise for someone is the one that they will do.
Beautifully said. So it sounds like if an individual um, has had certain activities taken off the table, such as they're told by a healthcare provider, do not run anymore, do not lift more than 25 pounds, etc., that it's important to recognize that those should be time bound and that meaning that they are a temporary thing that we can build someone back up to doing and being a part of that team.
Yeah. And it's a tricky conversation to navigate. And I wouldn't necessarily say, oh, well, that's BS that, they told you that, but more so, get curious, asking questions. Well, how can we maybe find ways for you to bridge back into that and find ways to, maybe create a little doubt or help just like chip away a little bit by little bit with, how can we maybe bridge kind of back to some of those preferred activities? Yeah.
Yeah, and that's like goes down to like providing hope, for people, and that's one of the best things we can ever do for humans that need it is just to provide them a sense of hope. And it
Absolutely.
sounds and one thing I want to kind of circle back to in that question of how can Pilates help someone with pelvic organ prolapse? It sounds like it can help someone get back to things they love to do, help them move, and all of these like global benefits of just exercise in general. Now, specifically with the pelvic organ prolapse, can we be expected as Pilates instructors to help um, reduce anatomical prolapse with a certain technique or anything like that?
No, I can say that fairly equivocally, unequivocally. So really, as far as the research that we have on prolapse and what exercise is beneficial or not beneficial, um, even when we're talking about like pelvic floor muscle training, we really don't know. So far, the evidence is actually not great for pelvic floor muscle training in its effect on improving anatomic pop. Can improve symptomatic pop. And we do think that there are, just to get like a little bit more nerdy for a minute, there are certain types of prolapse that might respond better. And there are certain positions that might be better for performing pelvic floor muscle training in individuals with prolapse. And that is in the supine position or even hips elevated, which is great news for Pilates because that's a lot of where that is happening. But and that, Pilates is not necessarily directly pelvic floor muscle training, but your pelvic floor muscles are certainly being used. So if we circle back to that really important distinction that pelvic organ prolapse is a problem of the connective tissues, not necessarily just the muscles. You can improve the muscles all day long, but it's not necessarily, it can help, but it's not going to necessarily change the changes to the connective tissue and the support systems. So for that, you really do need either a pessary support, which is um, an internal vaginal orthosis. Basically, it's a device that helps kind of support everything, and it maintains that support so that tissues can shorten. Or they do make external supports or surgical, surgery to um, help the prolapse. Although surgery, they do tend to have fairly high failure rates for different various types of prolapse. So to circle all the way back, can Pilates actually help anatomic prolapse? I don't think that we should expect that. Doesn't mean it's
Can
harmful, but
you knew
is
my
all
next
the muscle
question.
training in the world is probably not going to change that the support system.
Can Pilates make anatomical prolapse worse?
I would say it's rather unlikely.
It's a very, very good way to answer that. Good.
Yeah.
I hope that led some of you exhale listening. I have two more questions from the audience. The next question is, do hypopressive exercises help with pelvic organ prolapse?
They there is we're kind of really at the beginning of the research on hypopressives for pelvic organ prolapse. There are some studies that have come out that have given like some really good glimmers of hope. I can't say like unequivocally one way or the other. I will say that hypopressives are one thing that you can definitely try. Um, they're tricky and difficult. Do you know about hypopressives? Or maybe should I say just generally what for the podcast listeners what? So
Yeah, let them know.
okay, so hypopressive exercises are a particular type of exercise. There's a where you're trying to basically create a negative pressure system, where there's like these different movements, but a lot of like kind of sucking in and trying to think of a better way to put it. Look up hypopressives, and so there are basically like hypopressive. You can create a pelvic floor muscle kind of contraction with this like kind of negative pressure system, but it takes a lot of coordination, and I'm not great at hypopressives. Like, and I'm a fairly coordinated person, but it is one option for people that might be helpful, especially for an individual who did not have a really good um, volitional pelvic floor contraction. And a Pilates instructor might not know that unless they were told by either the individual went to pelvic therapy and they know that they don't have a good contraction, or they have a muscular tear of their pelvic floor called an avulsion. Then that's when the hypopressives can be really helpful for strengthening the pelvic floor and for kind of helping to kind of support the organ system. But in the case of both, hypopressive and pelvic floor muscle training and exercise aimed at the pelvic floor, all those things, you can't, to create long-term connective tissue change, you can't just, you have to have those systems kind of in place long-term. And you're not going to expect your muscles to be on all the time. You can't be like hypopressiving and walking around, so that's why you aren't necessarily going to expect those connective tissue changes with those exercises.
Well said. It sounds like a lot of this is contextual, or it continues to be.
Yeah.
And the last question is on a different topic. It is, what are your thoughts when someone has a hernia and doing intra-abdominal pressure management?
Yeah, so that's a good question. And, hernias, Um, I will say that hernias and, you know, hemorrhoids and prolapse, kind of all three of those have um, these kind of genetic underpinnings in people who are genetically predisposed to some of these connective tissue changes, and also people who maybe have less helpful intra-abdominal pressure management strategies, like they do a lot of bearing down or bearing out, pressuring out, um, might be also more prone to prolapse, hernias, hemorrhoids. So if someone already has a hernia or a prolapse or a hemorrhoid, you can use those. And I will say that there are different hernias in different places, but you can certainly use some the different components that I mentioned of modifying some of the symptoms to see how it feels. Now, if someone has, say, an abdominal wall hernia and they can feel when their hernia kind of like when they can feel it when some of their insides kind of start to kind of pop out, they can often manually kind of push those in. And so same thing with when there is an inguinal hernia, which is in the groin, or even people can have hernias in other places. Um, you might encourage those individuals to use those hernia symptoms to be a kind of a barometer for them. And again, we just kind of circle back to everything that I said about prolapse. It is taking people on a movement exploration and helping them, try this thing, better, worse, or the same. Try this thing, better, worse, or the same. But I would not take anything off of the table for someone with a hernia, even though that's frequently done. Again, because we are already doing these high pressure activities in our daily lives. And so let's train ourselves better because we do actually use less pressure when we're better trained. So we can help people in Pilates in all the various ways that we're helping people um, manage their symptoms, train, move, and they will actually use less pressure as they go. But again, pressure's
Well,
not the enemy.
yeah, the medicine, the poison is always in the dose. With that said, you're such a wealth of knowledge, and I really appreciate you taking the time here to be on the Evidence-Based Pilates Podcast, and you've just made a huge difference in the Pilates industry. For
Well,
any Pilates instructor who would like to connect with you, work with you in any way, how can they do so?
well, I'm the most active on Instagram. So my Instagram handle is at Terri Terri .elder.dpt. And I mean, at this point, I don't get enough direct messages to be bothered by it. So you can message me if you have a question. And then if you are interested in more on pelvic organ prolapse, there is the seminar that Adam mentioned that is available, and you can watch that at your leisure. It's online, and I hope if you'll put the link in the show notes, that would be great. And then I also have um, something coming up, and this is the first time I'm announcing it. It's on June 5th, and it's also with Anthony Lowe and Teresa Wasser, and we are doing another seminar on diastasis. So that's another really kind of hot topic, and a lot of this, I will say, also applies to diastasis because that's a pressure management issue, and I know that will be a valuable seminar for a lot of Pilates folks. So check those out and feel free to connect with me. And I love connecting with people. So let me know if you want me to follow back, and happy to grow my network of other professionals.
All right. Everything that Terry just mentioned is in the show notes. So you can go to the show notes and follow her on Instagram and check out all of her offerings. And I absolutely loved the seminar. Highly recommend it. Thank you again, Terry, and thank you for everyone who took the time to listen to this episode. We'll see you in the next one.
Thanks, everybody.